بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه وسلم أجمعين. اللهم انفعني بما علمتني وعلمني بما ينفعني وزدني علما إنك العليم الحكيم. اللهم أخرجنا من ظلمات الوهم وأكرمنا بنور الفهم وافتح علينا بمعرفة العلم وسهل أخلاقنا بالحلم. اللهم ارزقني نعمة الإخلاص لوجهك الكريم بكل ما أقول وبكل ما أفعل. آمين يا رب العالمين. My topic today is short talk about the disc nomenclature or disc terminology. The terminology for disc abnormalities is very confusing and inconsistent in the literature, and the recommendation of the Combined Task Forces of North America Spine Society and American Society of Spine Radiology and American Society of Neuroradiology, and these are the summary of this combined task. As we see here, the disc is this is the disc, this is 1 quarter, and this is second, third, fourth quarter. For classification purposes, the intervertebral disc is considered two-dimensional round or oval structure having 4 quadrants. We have bulging disc, we have annular fissure, and we have disc herniation. And we will see what is the difference between these. Disc bulging is a generalized displacement of the disc material 50 to 100% or presence of disc tissue circumferentially beyond the edge of the ring apophysis. As we see here, this is the vertebral body, and this is here the symmetric bulging circumferentially around the vertebra. And here we have, this is the vertebral body, and this is a symmetric bulging disc around the vertebra. Here we see should compare the size of the vertebral body with the disc. And this is, here we see normal vertebral L3 body with normal disc L3 for level. Here we have the L3 vertebral body, and this is the L3 vertebral body, and this is the symmetric circumferential bulging of the disc at the level of L3. And we see here there is loss of signal intensity of the nucleus pulposus, should be hyperintense, and it is hyperintense due to degeneration. Annular fissure is separation between the annular fibers and seen as high signal intensity on the T2 weighted images representing fluid or granulation tissue, and this may enhance with gadolinium. Disc herniation is defined as focal displacement of disc material less than 25% of disc circumference beyond the limits of the intervertebral disc. This is the focal type of disc herniation, and we have the large broad base type between 25 and 50% of disc circumference, as we see in this example. The disc herniation can be contained or uncontained. Contained disc herniation if the displaced portion is covered by outer annulus fibers and/or posterior longitudinal ligament. The margin of the contained disc protrusion are smooth in imaging. Disc herniation are uncontained when there is no such covering. As we see here, this is disc herniation with central and subarticular end type on the left side with displacement of the nerve root here on the left side. This is the S1 nerve root. What is disc protrusion? Disc protrusion indicates that the distance between the edge of the disc is less than the distance between the edge of the base. It means that the base is larger than the dome of the disc. As we see here, this is the base and this is the dome is larger than the disc. As we see here, there is L4, L5S1 disc herniation, and the hyperintense area, this is annular fissure posteriorly, and the disc herniation is central in location. What is the disc extrusion? Is present when the disc between the edge of the disc material is greater than the distance of the base. Means that this area AB diameter is larger than the transverse diameter, and extrusion is associated with defect of annulus fibers and usually non-contained. As we see here, the AB is larger than craniocaudal is larger than the AB diameter. One diameter is larger is enough. As we see here, this is the central disc protrusion and subarticular anti-localization with compression of the left nerve root, and this is the right nerve root here. The disc extrusion might be migrated or might be sequestrated. If it is migrated, displacement of the disc material away from the site of the disc extrusion, regardless whether it is sequestrated or not, either migrated up or down. And in sequestrated type, it is lost completely any continuity with the parent disc, as we see in this example. Here can be incontinuous with the parent disc or not. As we see here in the sagittal cut, disc extrusion, and here this is the axial type with migration downward, but it is still continuous with the maintaining continuity with the parent disc. And there is disc degeneration of this with node of the disc space. Here there is posterior annular or fissure tear with central disc protrusion on this patient, but it is still maintained with the parent disc. Further characterization to the posterior longitudinal related to the posterior longitudinal ligament. Some authors have distinguished displaced disc material as subligamentous, it is beneath the posterior longitudinal ligament, or extraligamentous, it is posterior and lateral to the posterior longitudinal ligament, or transligamentous or perforated displacement, usually extrusion of the disc material through the posterior longitudinal ligament. Intervertebral disc herniation or smaller node is herniated disc material in the vertical direction through a gap in the vertebral end plate. As we see here, herniation of disc material through a gap in the plate. Also here. Also in this example, we have T1 and T2, and we see the end plate herniation with type 2 Modic type. Localization of herniated disc. According to the axial localization, we have the central location and the subarticular location, foraminal location, and extraforaminal location or lateral. And we have the anterior localization. We have the sagittal localization at the level of the disc, confined between the vertebral end plates, suprapedicular between the superior end plate and the superior border of the pedicle, pedicular at the level of the pedicle, infrapedicular below lower margin of the pedicle to the inferior end plate. As we see here, this is the disc level, and this is the suprapedicular at the superior end plate with the superior end of the pedicle, and this is the pedicular at the level of the pedicle, and this is infrapedicular between the inferior end plates and the inferior margin of the pedicle. Modic classification, described by Modic, and it is the changes involving the end plates on the MRI. We have three types. We have the inflammatory type and the fatty type and the sclerotic type, and this is the Modic. The type 1 represent fibromuscular changes, vascular changes in the subcondylar bone marrow with edema and inflammation, and it is acute degenerative changes, and it is associated with pain, and the patient has high signal intensity in T2 and low signal intensity in T1. In type 2, it is represent fatty yellow changes, and it is distinguished with increased signal intensity in T1 and T2. And type 3, it is represent a replacement of bone with bony sclerosis with little residual marrow, and the sclerotic changes will be visible on the X-ray, and it is low signal intensity on T1 and T2. And here, this is the summary of the Modic changes. This is the type 1, low signal intensity in T1, high signal intensity in T2. This is the inflammatory, and this is the type, and this is the type 2. This is the fatty type. Fatty yellow changes. Fatty yellow type has high signal in T1 and high signal in T2, and the sclerotic type has low signal in T1 and low signal in T2. In summary, abnormal disc, either it is bulge or herniated. Bulge can be symmetric, can be asymmetric, and it is more than 180 degree. And herniation, it is between less than 180 degree. If it is less than 90 degree, it is focal with either protrusion or extrusion. Protrusion and extrusion, and the extrusion might be migrated or sequestrated, and the 90 to 180, it is a broad base. Thank you for listening and hoping to see you soon in another talk. سبحانك اللهم وبحمدك أشهد أن لا إله إلا أنت أستغفرك وأتوب إليك.